Dear patients, esteemed patient representatives, respected advocates, and all interested parties, I warmly welcome you to our interview today, in which we will present and discuss some highlights from the recently concluded ESMO Congress in Barcelona, focusing on the topic of lung cancer. As you can imagine, the ESMO Congress is a major European cancer congress that has, over the recent years, gained significant importance. It is the second largest cancer congress in the world and actually the most significant one in Europe. I am Michaela Neuenkirch, a lung cancer patient myself in the so-called palliative stage, meaning in a late stage, and my cancer is being kept under control with a targeted therapy because it has a specific genetic mutation. As a patient representative, I volunteer on the board of zielGENau e.V. This is a patient network for patients with targeted lung cancer therapy in later stages, but increasingly also in earlier stages, because there are now approved targeted therapies available for that. I strongly believe in patient competence, also in that patients with information and knowledge about their disease become knowledgeable experts in their own illness, because the better patients are informed about their illness and their available treatment options, the more confident and well-informed they can be in actually making decisions in collaboration with their medical professionals. And this indeed leads to a better quality of life, but above all also to a significantly improved therapy adherence, which is now also supported by some studies. I am very pleased to be working with Professor Bleckmann again and discussing interesting studies. Professor Bleckmann is the director of the West German Tumor Center in Münster and the head of medical oncology there, but she is also dedicated to research, and she conducts studies with her research group Bleckmann on tumor progression and metastasis. At the University of Münster, she also teaches medical oncology. Hello and welcome, Professor Bleckmann.
Yes, good morning, Ms. Neuenkirch, and thank you very much for the introduction. Dear patients, dear patient representatives, I would also like to warmly welcome you. I am pleased to be working together with you again. Ms. Neuenkirch, and I can only agree with your preface that it is very, very important that we as healthcare providers work as a team with the patients, see patients and their families, and only in this way we can have optimal designs for treatments, therapies, and everything related to them and achieve the best possible outcomes. So I am very pleased to be here with you, and here in Münster at the West German Tumor Center Network, we also have our own patient advisory board. This really is extremely important to me to truly integrate the patient's perspective into everything that happens in tumor centers. That's why, yes, this event here also finds very open ears and hearts and always brings much joy. Yes, and with that, I would say, let's start. We have selected a few studies for you. Of course, we cannot bring everything, but we have tried to make a selection for you also about the different types of lung cancer and also about the different stages, and we would simply go through them with you. Here you see the obligatory disclaimer and potential conflicts of interest, which have in no way influenced the composition of the slides. And with that, I would like to begin with the first study. I will present it to you a little, and then in the end, we will discuss together as a team what this specifically means for our patients. And the first study is the so-called MARIPOSA study, a study that focuses on the advanced non-small cell lung carcinoma group, specifically in such patients with EGFR mutations. I will show this again here. So we are now in stage 4, and we are discussing the area where we can perform targeted therapy, specifically here with the EGFR tyrosine kinase inhibitors. I have brought this along again. You can check the guidelines or also Oncopedia, which is what, for example, the treating physicians like to look into, and there you can orient yourself and determine in which treatment arm you are in. And you can already see here with EGFR, here I have put a red circle around it. We also need to distinguish between quite different mutations. That makes it a bit more complex. And I will show it to you again here. So we always first start with molecular diagnostics to find out whether there is a so-called driver in the tumor that significantly controls tumor growth. And then if there is the driver we have found, we check whether targeted treatment can also be applied. And we are now talking about the upper part, namely EGFR mutations. They are not rare at all, as you can see in the green section of the pie chart. And there are already various approvals for the so-called common EGFR mutations, which are 2, the L858R and the exon 19 deletion. And so far, our standard of treatment, I would say, has been the treatment with osimertinib as a third-generation tyrosine kinase inhibitor in monotherapy, and we have been very pleased for a long time that we can treat without a chemotherapy. Recently, for the sake of completeness, there was approval based on the FLORA study, which examined whether we could achieve even better therapy efficiency by adding chemotherapy to osimertinib, which was our standard without chemotherapy. The study is positive for PFS, and the approval has now been granted, and I explain this to you because the MARIPOSA study is now also entering this line, posing the question, can we further improve the first-line treatment in the EGFR mutated group with the COMBs, that is the common EGFR mutations? It is very important to look closely at what type of EGFR mutation is present. Now let's take a look at this study. So these are the untreated stage 4 or locally advanced or metastatic patients with common EGFR mutations, and they have received either our previous gold standard, the osimertinib, or a combination including a third-generation tyrosine kinase inhibitor. This is only the lazertinib here, and the amivantamab. The amivantamab is a so-called bispecific antibody against EGFR and also against MED. In addition, we have already observed at previous medical congresses that this study is positive. And in this analysis here, which we have just seen at the ESMO, the colleagues have re-examined how resistance development is progressing when we now use this other targeted therapy. Here you can see once again a bit about the objectives of the study. I have already explained a little bit about what the medications are. And now it's about how patients respond and what the resistance patterns are. And let's take a look at them now, perhaps briefly in the preface. We know that when we treat with EGFR TKIs, particularly osimertinib, that a so-called MED amplification, which will also be discussed in the next study, is one of the more common resistance mechanisms. And what we can see here now, here they have compared how are the resistance mechanisms under osimertinib alone compared to how are they when we do a combination with the bispecific antibody and the TKI. And there you see that, for example, MED amplification occurs significantly less frequently, 13.6 versus 4.4%, and this applies also for other known resistance mechanisms. So to summarize here already, the resistance patterns are always dependent on the drugs we administer. And when we introduce new substances into the first line of treatment, also completely changes the resistance profile. Here it is shown again for the other resistance mechanisms that play a role. There are the differences, not quite as significant now, at least not with the so-called off-target resistances, which have nothing to do with the actual target structure. It is also relatively logical, I think, that where the targeted treatment intervenes, the resistances change, and that everything which is not significantly different regardless of the intervention. So in conclusion, we have a study here that is indeed very positive for PFS in the combination with amivantamab plus lazertinib against our gold standard. As mentioned, this is a PFS difference, which we observed there. I must apologize. It's essential for you to always step in immediately whenever I use medical jargon. So progression-free survival does not mean overall survival, but rather progression-free survival. As you can see, we clearly have that here in the endpoint. Here it has again been analyzed to see how the resistances are. They are different. We are expecting this study to approval. That's why we brought it here for you, because it is essentially the third regimen in the alliance of how we can design the first-line therapy. We certainly also need the endpoint of overall survival. I always find it important that it also has a benefit. And what I haven't talked about yet, but of course we want to address it here, amivantamab has its own unique side effect profile. It's logical anyway. When I take two substances, more side effects occur, and amivantamab has once again something very special, and I believe that this is a very important point in the treatment. Ideally, these are long-term treatments. Then toxicities play a huge role in correlation with quality of life, but we need to deal with this because we will probably soon have 3 regimens in the first-line selection. So this as a brief introduction to MARIPOSA, and I am curious, Frau Neuenkirch, about what you have to say about it and how you assess it.
Yes, I also find this study extremely interesting. And if I now think about how the situation was 3 or 4 years ago for EGFR mutated advanced lung cancer, now within just approximately 1.5 years, there are 2 additional ways to effectively treat it, either by using chemotherapy, as mentioned earlier, or now, as this study examines, lazertinib and amivantamab combined. I find that a significant advantage for the patients. I would be interested, as it is on one hand, the patient who is informed about the side effects and be aware of what side effects are coming their way. But would you weigh, in your opinion, for which patient what is more suitable or ideal? For example, do they now play a role in their treatment? A possible decision for this therapy regimen may potentially depend on whether there are additional mutations. If the resistance mutations seem to be fewer here, potentially, perhaps, is it then for patients who still have additional mutations, although they showed in the slide that it doesn't play a significant and major role, this might potentially play a role in the decision for which it could influence the comprehensive therapy regimen, which will then be discussed in detail with the patient?
Yes, I think that is a very important point you raise. In the question, so does everyone simply get the new regimes now? I think from how it looks at the moment, it is rather not the reality, but it will be subgroups that we identify where we try to extract that from the studies, who then indeed receive the somewhat more toxic, that is combination treatments. So it is now also for the FLORA-2 study in everyday life. And there could be, for example, if we stick with FLORA-2 because it is already approved, there are, for example, an analysis that such patients, even with CNS metastases particularly, benefit from the addition of chemotherapy, which I still do not fully understand from a tumor biology perspective, because it was always said that chemotherapy is less effective in reaching the central nervous system more effectively than the small tyrosine kinase inhibitors, but still we have the benefit there.
And that is perhaps the blood-brain barrier a little bit softens the chemotherapy, that it is not really the chemotherapy that works, but that the paving the way for osimertinib, which is known for its good CNS penetration, to be more accessible.
Yes, it must be something like that. I just wanted to say it's indeed actually somewhat counterintuitive, but those could be, for example, subgroups. I think that one really then patients must be decided on individually and subgroups individually. And to your so-called second question about the resistances, so it's interesting to see here that the resistance pattern is changing. I believe that it is naturally expected to change. And then it is rather, again, the challenge when the resistance pattern is different after the first line, then here what to do then in the second line. So far in the second line, we have focused on then, for example, to choose a therapy that targets MET amplifications, effectiveness has, and that is probably no longer sensible after the MARIPOSA regime, and we definitely have to learn that again.
Yes, indeed, and with the side effect profile, it is absolutely, undoubtedly. Then also the question arises, do you perhaps try it out? And if the side effects potentially for the patient are not feasible? Well, you see, there are those who can tolerate it without major or noticeable changes or problems in any significant way, or those that are indeed well tolerable over a longer period, and some that, for example, get big skin reactions. Could one then truly switch to another standard?
Exactly, indeed, that is one of the main points. We can perhaps briefly outline it as well. So amivantamab naturally also has toxicity on the skin and mucous membranes, as we generally know this from the EGFR TKIs. However, the toxicity here is pronounced, so that is, I believe, very important to know about osimertinib, which is relatively well tolerated, is not comparable in terms of intensity, and then there are such infusion-associated side effects. This is still a medication administered intravenously at present, so allergic reactions indeed play a role there. And there can be thromboembolic complications, also pulmonary embolism, thrombosis. The latter two are expected to have a more favorable course if one subcutaneous form of application exists, which has been developed but not approved. So there, I believe that the thromboembolisms and these allergic reactions, that this then also better. The issue with the skin remains, I believe, the great challenge. And that is, of course, something that then also restricts quality of life. We are challenged to manage it in such a way that it also works well in everyday life. And if it doesn't work, you have to de-escalate the regimen, that's clear.
Exactly, and that means for the patient, above all, stay in close contact with their oncologist and maintain regular communication to determine what can be arranged and what perhaps can be done to facilitate strict adherence to the prescribed therapy. Yes, indeed, then thank you very much for the first detailed study and the insightful discussion and your comments on it. We are now basically moving on immediately to the next MARIPOSA study. It also involves advanced and comprehensive non-simultaneous lung cancer with EGFR mutations in the advanced stage. And there it is also about amivantamab but with chemo added or with chemo alone in the later line, for example, or under osimertinib. I hand it back over to you, Professor Bleckmann.
Yes, thank you very much. Yes, exactly. We are staying on track. This also fits well thematically, and we are now moving into the second phase line. So what do we do exactly after first line therapy in the EGFR mutated situation? It has already been briefly explained that the question of which resistance is present is always a very important one. And if you take a look down here, I have brought this along for you. When we use osimertinib in the first line treatment shows how diverse the resistance mechanisms are. And here, all the way on the right page, you see 15%, for example, this MED amplification. We have just looked at that. When we treat in the first line against MED, it is naturally different. But so it would be now if we are after osimertinib. And now we basically take a look at the MARIPOSA-2 study that specifically addresses the question of how we treat after a comprehensive first-line therapy in the EGFR mutated situation. You see it here again. So this is again the advanced metastatic patient group with EGFR mutation, and they have already received targeted treatment with the advanced third-generation tyrosine kinase inhibitor osimertinib therapy. Here you see at once that the question was then asked, how should we proceed with treatment? Should we hear a classical chemotherapy platinum doublet, or should we use platinum doublet? So blood doublet always means a combination of a platinum and another medication plus targeted therapy. Again, with the bispecific antibody you have already been introduced to, amivantamab with EGFR and MED targeting. And the endpoint is here, among other things, the overall survival, but also time to symptom deterioration and therapy discontinuation. And now let's take a look at this here. You can see the two arms again. So chemo alone against chemo with targeted therapy. Brief comment, this has been applied here, regardless of whether the resistance mechanism had been tested. So the data we will certainly see at one of the congresses. I am also very curious about that, but the patients who then experienced progression under osimertinib simply received it. And now we will take a look at the primary endpoint here, which is with the overall survival. And if you take a look at this, you will see here directly after 18 months that 50% in the combination arm compared to 40% in the chemotherapy-only arm survive, and that with a hazard ratio of 0.73. So this is indeed a positive outcome. And then you can also look at the other endpoints. So for the combination, it is like this. When you look at when the disease progresses again, it is, of course, or then it is indeed naturally much more commonplace if we only have chemotherapy in comparison regarding the combination. So we have better symptom control for the combination. We have a longer time until therapy discontinuation for the combination of amivantamab plus chemotherapy. And we also have a longer time until the next line of therapy if you consider here in the combination treated with amivantamab plus chemotherapy. So in conclusion, the addition of amivantamab with chemotherapy in the second-line treatment for EGFR mutated conditions improves overall survival and also definitely improves all the other endpoints. So until one has symptoms under which one gets worse, until one has to stop the therapy, and it takes longer until the next line of therapy is needed. So this is indeed exciting, quite independently of the resistance mechanism. And I may also say that this treatment has just been approved. So there are not only the study data that we show you here again with these additional endpoints, but the regime is now approved. And thus we now have, so to speak, after EGFR TKI failure, a targeted treatment option in label. I would always advocate that we still test, so perform a biopsy, test, conduct broad molecular profiling, but we can continue treatment right here with a targeted combination therapy. And that is, of course, a great added value from my perspective at this point.
Definitely, because for many years there was really only chemotherapy as a viable and effective further treatment option. And now, as the old saying goes, it seems that the number of arrows in the quiver has either doubled or even tripled over time.
I always say that too, arrows in the quiver. It's great that you say that too.
Yes, I have got this from my oncologist. This is a beneficial outcome for all patients, that there are just more possibilities available, also because they mentioned molecular testing. It is indeed, as you say, extremely important because there are also possibilities. So it also depends on the resistance. And then, of course, the better prepared you are, the more precise you know the opponent. That is what led to the failure of osimertinib. And if this now leads to, for example, if a MET amplification becomes more pronounced, there are still possibilities available. except for amivantamab with another targeted medication, such as, for example, with osimertinib is a medication that is often used in combination with other treatments. As a patient with advanced stages of illness, I find myself feeling happy when there are opportunities to broadly and thoroughly decide, in consultation with your healthcare provider, what to do next, to carefully consider all options. And I would say, certainly, the longer one can continue therapies even after the first-line treatment, the more time it also provides to wait for the approval of additional new therapy lines. There is indeed so much occurring in lung cancer research and developments that one can also take time with follow-up therapies, provides access, perhaps again, to a study or a newly approved second-line treatment, such as third-line, however, to reach.
Yes, absolutely. And one must be in conversation together. One should then test. We have just emphasized this together. The testing always takes a moment, and these are very complex results that come out. I can only advocate for ensuring that these are included and discussed in the molecular tumor boards at the Centers for Personalized Medicine, because that is really at the highest level as well. Recommendations that come and can further assist the patients, and that one always considering together in conversation what is the best option now. And here a real added value in the treatment setting, perhaps a brief comment. This regime, in my view, it obviously makes no sense if one has been treated with MARIPOSA beforehand, assuming it is approved. So it is also quite clear that we are now dealing with the MARIPOSA-2 study, which has also been approved, is to have an option after osimertinib when given alone, perhaps also with osimertinib plus chemo, but not if we already had amivantamab in the first line. Therefore, it is indeed a very vibrant setting in which we always operate. But that is, of course, it's quite clear that one must consider together with the patients what to choose and when, so that the sequence fits as well, because not everything fits in order.
And that also makes it so important for the patient to be in a specialized center, to be advised or to seek advice, or at least to perhaps obtain a second opinion, so that the various minds who deal with all the available study and therapy options multiple times daily engage, then be able to provide the necessary and important guidance on what follows next.
Yes, we offer that for all patients, and it doesn't mean at all that one always has to travel to the center for treatment. Perhaps we can emphasize here again that only a recommendation can be given. And if that is an approved treatment option and not a study or something like that, can then also be implemented locally by the oncological colleague. This is also very important, that one does not need to be afraid of it, that you always have to go to the distant center.
Exactly. Also, your medical colleagues who can basically also seek advice there, so that it becomes a kind of collaboration for the ultimate benefit of the patients. So that is what interests us patients the most, ultimately, that things will continue to go well for us. Yes, thank you very much for the discussion of MARIPOSA-2. We are going now to the next exciting part. There we will focus on the ALKOVE-1 study, which is primarily about a new tyrosine kinase inhibitor, TKI, that has shown promising results in clinical trials for patients with ALK-mutated non-small cell lung cancer. And the study is about dose finding, safety, and efficacy. It is essentially observed how effective this medication is in differently pre-treated regarding ALK-positive lung cancer patients. But I will hand it back over to Professor Bleckmann.
Yes, thank you very much. Now we are moving from EGFR to ALK. As you can already see on this slide, we have brought an exciting study. We tell also why we found them so exciting. Here again is our cake, which you already know. And we are now in the ALK positive group. This is the purple piece of cake here. And you see that this is significantly less common than the EGFR mutation we just discussed. We already have many tyrosine kinase inhibitors for ALK approved, which are the small molecules, first, second, third generation. And now we will show you a study with a fourth generation ALK TKI. Here again, briefly an overview. If you look what is allowed when it is in a so-called treatment context, then one can, for example, look at Oncopedia. And here you can already see in the first line, it already plays a role, and we have many different options. Also briefly commented here, just like with EGFR, it is important when there is progression under a substance that one conducts molecular analyses again and looks at what the mechanism is, why the medication no longer works. There are many different mutations. You can see them depicted wildly in the table here. And depending on which mutations are present, one can then look at how to treat. So my plea is always also fight for the fact that if you are undergoing a targeted therapy that you are tested during progression. For this, new material usually needs to be taken. This is, of course, also a certain burden. I'm fully aware of that, but it offers a huge chance to then also understand why the medication is no longer effective and perhaps to be able to apply other new medications. That's just as a preface. And with that, we look directly into the ALKOVE-1 study, that is ALK-positive patients. And they are in principle, naturally pretreated. 133 patients have been examined here, and of them were almost all pretreated. With this new NVL-655, I wouldn't have to notice. We remember simply fourth generation ALKed key. And as mentioned, it was indeed an early study, of course, but we wanted to simply bring you the signals and, of course, definitely include them in the question for you. What this means for someone who is currently on medication and what future options are available. And if we take a look at this now, you can see it presented here in this table, that this is a patient group that has been extensively pretreated, both first and have received second and third generation ALK keys in prior treatment, and then on the medication with the new drug came, and that also the various resistance mechanisms presented here. I have already briefly shown that this is also complex, and such resistances were present here, which we know where even ALK third generation TKIs no longer work. I believe this is the most important message for you here. And here it is shown again that many patients on average had undergone 3 or even 4 treatments. So, and now you can clearly observe here indeed, in essence, these early results. What is being measured here? In the earlier studies, this response rate, abbreviated as ORR, is always objective response rate. Objective response rate is the endpoint that we always have. And if you look at it now, then certainly regardless of how they were pre-treated, but for example, also those who even had the best and most advanced ALK-TKI that we have on the market and in approval, we then have here in approximately 50% mentioned again. I find that very promising for such a pre-treated patient group with the common resistance mutations. Here you can see again represented, so to speak, indeed in the different groups. And we actually then also with the patients, especially those who had even received lorlatinib beforehand, still showed a response. And those who have not yet had lorlatinib naturally have the very best response rates here, because then, of course, the resistance profile is probably even more favorable. Here it is shown again, like the different types of resistance that exist. I believe we don't need to look at the details. What is important for you is the message or the information that this all still works against resistance mutations, and all of this with a very, very good side effect profile. I will say more about that in a moment. Here you can first see again the response in the CNS. That's something I haven't emphasized yet, especially regarding the ALK positive individuals. Patients, the occurrence of metastases in the brain, that is in the central nervous system, is something that occurs frequently, and that is why the disease control is of essential importance, because it is directly related to quality of life. CNS, metastases, and quality of life are very, very important topics that belong together. Now let's take another look at the side effects. And this is actually also interesting here, that the side effect profile is really very, I find in my experience, manageable and straightforward. So the higher grade toxicities from grade 3 onwards are always the really relevant ones. They truly are manageable here a bit in the area of the liver, and otherwise grade 4 only once regarding the liver, and no other side effect components or organs that we here see. And if we compare this again also with the third generation TKI lorlatinib, I think this is simply an exemplary example of how good we have become, really very precisely. Here we are indeed once again to develop new medications that once address binding pockets in such a way that common resistance mutations are no longer effective, have been developed and are then so precisely tailored to the target that the side effects are manageable. I think this is crucial. That's why we have done this for you and brought along that it is now possible with the better biological understanding and these options to design medications. It's a huge opportunity for us then also to develop new generations of medications that firstly work well even in all known resistance settings, that are well tolerated. And yes, we have summarized this for you here again. And I believe that this is the path that brings a lot of hope in every targeted setting, if you know the driver.
Correct, and that this is still an option, even if there are many tyrosine kinase inhibitors, TKIs, available for patients, that there is light at the end of the tunnel. I wouldn't say that right now, but it definitely shows some very hopeful and promising results for this particular situation. which may potentially lead to an approval where things are now advancing with the process. In the previous slide, you have had a sentence about TRK-related nerve damage. Could you please briefly explain again that TRK-induced nerve damage could have been avoided?
Exactly. I can briefly illustrate that again. I have also just briefly touched upon. So we have, particularly with our current third generation TKI, with lorlatinib, yes, a somewhat unique side effect profile. We have things which we know from the other second generation TKIs, and we also have a central nervous side effect profile that exists for lorlatinib. It is all manageable as well. But that's something you need to know. And interestingly, we see this in the fourth generation TKI, not at all. And that is, of course, super charming because that is one of the main points for lorlatinib, which is always discussed and where patients must be informed, and especially the relatives in case of such side effects are coming. And this substance does not have that, and that's why I find it so charming that it has been successful to design this substance in such a way that it does not cause these side effects anymore. That really convinced me.
I can understand that. That will certainly convince a patient as well. However, it must also be said that lorlatinib is not for all such severe nerve damage prevails. It also comes down to communication with the oncologist and how significantly this side effect actually manifests. Indeed, truly, that is now nothing that must generally and definitely come, but it is, of course, very important to discuss, which brings us back to the doctor-patient conversation, where it is important to stay in close contact.
Yes, thank you for emphasizing that again. I did not want to postulate that in any way, but it is indeed essentially something that needs to be considered and naturally in conversation as well. Inform and educate about it without it occurring for everyone. It is also a very easily manageable substance that is super potent, that is completely undisputed. However, for me, I really like that with the new design, this issue hardly occurs anymore.
This development is expected to bring great satisfaction to patients who are ALK positive. Thank you for this summary. We are engaged in the following with, or it's mainly Professor Bleckmann who's engaged in it. I just simply ask and jump in. We are addressing two studies. One is only mentioned quickly. It is about KRAS-mutated non-small cell lung cancer. Although KRAS is a very common mutation, but not necessarily straightforward to treat, I now hand over more of the conversation to you so that you can explain the two studies to us.
Very gladly, Ms. Neuenkirch. We will now take you again into the KRAS-mutated group. You can also see this here in the red pie slice. This is the most common driver in lung cancer, for which we had no very specific and effective targeted option for a long time. In the treatment, we were significantly further along with the other drivers, and there is an option only for one subgroup, which is very important, specifically for the KRAS G12C point mutation. One should not only look at KRAS, but also a bit more precisely to see which specific point mutation it is. However, we have approved two medications for it. Those are sotorasib and adagrasib. That's great. Both are approved in the second line. I have brought this back for you again. Sotorasib was the first to be approved for patients with KRAS G12C. You can see it here once. That's how precise you have to be. You always have to look at these findings, which have already been pre-treated with at least one therapy line. And now newly approved is also adagrasib. It is approved by the EMA. But I must also briefly say here, it is not yet available on the German market. I believe it is now expected to be available in Q1 of the coming year. So that's just simply for your information. And the first thing we have brought for you, we have now again received an update from the Crystal-12 study. This is the study that has tested in the second line treatment adagrasib in comparison to chemotherapy in the KRAS G12C mutated group. We already know the study. We have, of course, already seen it at other congresses and has also led to approval by the EMA. And here we have seen another update. So just to reiterate for you, in the environment with adagrasib, precisely the second substance that we hopefully will soon have in our hands, tested in comparison to the sole use second-line chemotherapy. And what we have additionally brought to you in this line, I have already emphasized that sotorasib and adagrasib are approved for second-line treatment. Now, of course, there is a plethora of studies addressing the question, if we can't make the treatment targeted already in the first line if we have KRAS G12C mutations? And the CRYSTAL-7 study is addressing exactly this question, specifically in the high PD-L1 expressing group. So as you can see here, PD-L1 TPS greater than or equal to 50 plus, then here a KRAS mutation, and then a therapeutic trial will be conducted here, immunotherapy plus KRAS inhibitor. Let's take a look at it now. Who is it relevant for? It is relevant for all patients with KRAS G12C mutations in the question if targeted therapy in the first-line treatment is better than our standard. Our standard is then immunotherapy or immunochemotherapy in the setting, and we are now checking here how it looks. Here it is shown again how the design is. So untreated, high PD-L1 expression, KRAS G12C mutated, and then adagrasib plus pembrolizumab, so immunotherapy versus pembrolizumab alone. The primary endpoint is disease-free survival and the overall survival. I believe we have already discussed well what the study investigates, and is, I think, once again, a very important setting in the question of whether targeted therapy in the first line is better than what we have been doing so far, and that first needs to be proven. The side effect profile, which we have already presented to you here, is basically what we know from adagrasib, also from the CRYSTAL-12 study, are predominantly liver and gastrointestinal problems. However, they were mild here, although in combination with immunotherapy, and one is particularly concerned about the liver, also due to autoimmune hepatitis, but that doesn't seem to have been a signal here. Yes. And now we are looking at these earlier results that we have here. And you see the overall response rate, which is quite significant, stands at a total of 63%, and the median duration of the response and the median time to progression, these have not yet been reached here. So the patients are responding to the treatment, and 84% also have a stable disease situation now here in the early setting. Yes, the study is now currently being initiated. Then in reality here in the phase 3 setting, and in this context, the study recruits. So you can accordingly thoroughly examine this again based on inclusion and exclusion criteria, and possibly even become a study patient. This is not the only study. We have just simply brought this as a typical example, but there are many studies that cover the very different KRAS inhibitors. Here is adagrasib, but there are many. Almost every research-based pharmaceutical industry has something up its sleeve, and if you are KRAS G12C mutated, in any case, I would suggest checking the study options, because there are quite a lot of first-line studies. That was the important message here, and I am eager to see what the results will be. The first data regarding the response rate are definitely promising, and I am curious, maybe we can, like in the next year, we might already report on an approval or discuss whether the first-line standard targeted approach is then broken, and then we also go into KRAS with the substances in the first line.
Thank you. What is, of course, for the patients with this KRAS mutation would be very important, because TKI is generally more tolerable, and as you also mentioned, it is important to note that with adagrasib, the side effect profile regarding the liver is also good. I find that promising. Are sotorasib and adagrasib relatively equally effective in its mechanism of action, or does sotorasib have stronger liver side effects? Well, I mean, it's nice that adagrasib is currently approved, but unfortunately it is not yet available. So currently sotorasib is for the KRAS patients with the G12 mutation, the only available option. What do you say about that?
Yes, exactly. So I believe that is the most important point also with sotorasib. There was, for example, the recommendation, especially because of the toxicity in the liver, that there should also be a certain specific interval since the last immunotherapy. There is this recommendation for adagrasib, not yet. So there is no recommendation that there should be a specific interval. Although we cannot report any real-world results to you yet because we do not have this in our hands yet. But in the study, there were apparently no signals that we have a time-dependent toxicity. Otherwise, in itself, the side effect profile of these two small molecules that bind to KRAS G12C are relatively similar, because they also have a quite similar, so to speak, binding site. We have already briefly mentioned that there are many new substances for KRAS G12C that are in development, and there are also some which probably have a different or even more favorable side effect profile because they have a different binding and activity mechanism. But basically, I would say essentially with adagrasib, What is charming, there should really not be dependent on the last immunotherapy. This would be an added value in the treatment regarding liver toxicity.
I'm really glad to hear that news. Now, for the CRAS patients, there will maybe be a new colorful array of treatment options in the coming years. I am very, very hopeful and hope above all that research progresses quickly and effectively and new treatment options become possible because, as you mentioned earlier, for CRAS is not as natural in a way that is typically observed in cases of other types of mutations in the context of non-small cell lung cancer. Absolutely. Then thank you very much for this study. And to conclude our targeted therapies, you are now presenting the study on a new ROS1 TKI that is effective in later stage ROS1 mutated lung cancer. And therefore, I hand over to you expectantly, Professor Bleckmann.
Yes, exactly. Let's conclude with ROS. Also an important group, just a little bit smaller. Let's take a look at this. We have brought back again this so that we can orient ourselves in which piece of the pie chart we are. And now we are presently here in this orange section for the ARROS-1 fusions. This is almost a little different. Again, ALK are also fusions and ARROS are also fusions. In contrast, regarding the mutations we just discussed with CRAS, and as you can see, we have already medications in approval in the various TKI generations, the Critzo and the entrectinib, and there are already study data for other substances, but they have not been approved yet. And we have also certainly brought you a study of the next generation of this ARROS TKIs. This is zidesamtinib, an innovative drug development, and fundamentally in essence which is similar to what we just showed you from the ALKOVE-1 study. So here again, precise adjustments to the resistance mutations and a favorable side effect profile in the truly new opportunities to develop medications. For whom is this relevant? Of course, primarily for the ARROS fusion positive patients. And you can see it right here now. Of course, earlier study data that we have brought to you, pre-treated patient group, ARROS-1 fusion positive, now being treated with the new ARROS TKI zidesamtinib. And now let's see how the effectiveness looks. You can see it here again. It is a monotherapy arm in a pre-treated patient group, and it is about effectiveness and side effects. And if we take a look at it directly here, as you can see, here are the dose escalations. I believe we don't need to go into detail about that, but start with the recommended dose of 100 milligrams per day are indicated here. Let's take a look at the study population right away. And you can see that this is a heavily pretreated patient group. 66% had previously already chemotherapy, and almost 70% of the patients had previously 2 or more ARROS TKIs. I had already shown you earlier which ones are approved in our region with Critzo and entrectinib. And then, of course, there are also the others, the Lorla and the repotrectinib, which naturally also have their effectiveness here, but they are formally not approved here. And we are looking again at the response rates because it is an early study. And depending on where you look here, you can see that, for example, the response rate here in the collective that had not yet had repotrectinib is 51%. Overall is 44%. A bit different, of course, depending on which resistance mutation is present and how the effectiveness of the substance is. But we actually also, in a truly extensively pretreated patient group here, then already with 2 or more ARROS TKIs, still an overall response rate of 41%. And from my perspective, that is already very, very promising in this heavily pretreated patient group. Here you can see, so to speak, the response again, shown what a sustained response is indeed, even in a heavily pretreated patient group. And with ROS, it is similar to ALK, which we mentioned earlier. An important CNS efficacy is of absolutely essential importance for our patients. And here we have just also another endpoint, the response in the so-called head or CNS, that is intracranial response rate, also 50%, are only very few patients, I want to say here. But still, I believe it is a very important endpoint that we also really measure the effectiveness in the central nervous system. Perhaps in conclusion, briefly on the side effects. Not so many patients have been treated accordingly yet, and you see that edema, elevated liver values, and weight gain are indeed the main topics. In summary, indeed, something is also developing here in the ARROS positive group. The new TKIs are in preparation and are now first showing good effectiveness here in the early study data. And I am curious to see what results the phase 2 study will bring, just as for the ALK-TKI that we looked at earlier. But I believe that there are also good signals here that give me hope that the 4th generation will also reach patients.
Yes, I truly believe that this gives a lot of patients with ROS, I hope, because as mentioned, the tumor response in the brain is indeed always a consideration that is important for many, both those individuals with brain metastases and those who want to avoid developing them in the future of her condition. And also, as already mentioned with ALKOVE, that there are no side effects that affect the nervous system, such as various neurological disorders can be observed. These are certainly two very important points for ROS1 patients who require a subsequent line of treatment because the previous TKI is no longer effective. Yes, so I am certainly full of hope for the patients that this will be a serious candidate and that this will be reflected in phase 2 or possibly then phase 3 studies, and maybe there will be an approval.
Yes, I believe that too in due time as well. And as I have mentioned before, I find it particularly great how precisely these medications are now being developed and designed for the resistances and the whole thing under an optimization of the side effects. And I believe that this is really something that has only become possible in today's times. And of course, it's fun to see that.
Yes, the experience that researchers gain and the research in lung cancer research moves so incredibly fast, which indeed also brings me great joy as a patient representative to watch because it brings so much optimism and hope for the patients. Yes, dear Professor Bleckmann, I sincerely thank you for the numerous and valuable studies here for targeted therapies, such as in non-small cell lung cancer, with mutation or fusion that we have thoroughly looked at in great detail and depth. We have a second part to which we will jump next and to which we would like to welcome or invite you separately once again. But here, at this point, I would like to say thank you, Professor Bleckmann, and bid farewell to you, interested listeners. Perhaps we will indeed see each other again in the next part.
Yes, thank you very much, Michaela Neuenkirch, and thank you all for listening. We hope we were able to bring you a few exciting studies, and we have a second take where we have prepared 2 studies for you on the early stages. If you feel like taking a look, thank you very much.